An oropharyngeal airway, or OPA, is used when the patient's GCS score is less than 8, or when the patient's verbal response is under 2. So first, tilt the head back to open up the airway. Next, measure the OPA from the corner of the mouth to the mandible. So this one's a bit too big. Yep, this one's good. Now insert the OPA with the tip pointing towards the curve of the mouth and rotate 180 degrees, gently advancing the airway, avoiding catching the tongue. Complications of using an OPA includes inducing vomiting if the OPA is too large, damage to the oral pharynx, or worsening airway obstruction if the tongue is pushed posteriorly. A nasopharyngeal airway, or NPA, is another form of airway management. So first, you measure the NPA from the nostril to the mandible. So that's a bit too short. Yep, that's right. Okay. Next, you lubricate the NPA using a water-soluble lubricant, and you insert it 90 degrees to the patient's face. If any resistance is met, rotate the NPA 180 degrees. If resistance is too great, take out the NPA and insert it into the other nostril. The flange of the NPA should be resting on the patient's nostril. Benefits of using an NPA is that it doesn't induce a gag reflex. It can be inserted into a patient with a high GCS score, or if they have trismus, also known as lockjaw. A complication of using an NPA is if the patient has a base of skull fracture. The NPA also has the potential to cause nasal bleeding. Alright, so before suctioning, ensure that the patient is in a recovery position, and first test the suction unit by turning it on and occluding the tube until it reaches about 350 mm per mercury. If it does not reach that, troubleshoot for any leakages. There is a hole in the rigid catheter and it only suctions when I put my thumb over it. So first you insert the catheter into the mouth as far as you can see into the oral pharynx, and you only suction on the way out. So in a circular motion, and you only suction on the way out. And you can only do this for less than 10 seconds. Complications from using the suction includes vomiting, hypoxia, bradycardia, aspirations, and soft tissue trauma. Lastly, the rigid catheter should not be used in a moving vehicle. Identify that this is an oxygen tank. There will be 3 ports on the pillar valve. It will be labeled oxygen, and the tank will usually be white and black. So before giving oxygen, ensure that this little black seal called the Bodak seal is intact and in the middle of the regulator like so, and if it is damaged, just replace it. So you want to line up the prongs on the regulator with the pillar valves on the oxygen tank, and you just tighten this lever here. And once it is all lined up, you just do a quarter turn to lock it in place. And to unlock the oxygen tank and to have it flow through the regulator, you just turn the top knob here like so, and you can see how much oxygen is in the tank. So that is 2,200 psi, which is really good. And to administer oxygen to the patient, you just turn the side lever here like so, and oxygen will start flowing through the tank out of the regulator. So the mask we'll be using today is a non-rebreathable mask, which delivers 90% oxygen at a flow rate of between 10 to 15 liters per minute. This is used when high concentration oxygen is required, but the patient does not need assisted breathing. So when using the mask, disconnect the tubing to the regulator like so, and turn it all the way up to 10 liters, and the reservoir should start filling. And when you are on a stretcher, just place the oxygen tank in between the patient's legs so it doesn't fall over. And just ask for consent first. So I'm just going to place an oxygen mask on you. Just place it, ensuring that you do not catch his ears, and it should be just resting on top of his ears. And you just tighten the green strings to ensure that the seal is tight and fitting, and you can press some on the nose clip as well. To remove the regulator from the oxygen tank, first you want to lock the top knob here, and then you want to flush out any oxygen that's in the regulator. So just turn this all the way up, and you can see the gauge reading the PSI, it's rapidly decreasing. So now once it's reached 0, you just loosen this lever here, and it's all done. Before using the bag valve mask, ensure that there are no leaks in the BVM itself. So I'm just going to occlude it like so, and squeeze on it so there's no leaks and it's good. And I'll be checking whether the reservoir bag is able to fill adequately and that there are no leaks. So yep, that's good. Okay. Next, I'm going to do a head tilt chin lift just to open up the patient's airway and also use an OPA. You can use an NPA as well. Okay, next I'm going to connect the BVM to an oxygen tank with a flow rate of at least 10 liters. This is to ensure that the reservoir fills, like so. And I'll be placing the mask from the head end of the patient. And as I'm a single user, I'll be adopting a CE grip. Okay, like so. I'll inflate once, looking for chest rise and gastric inflation. So when ventilating, you want to be ventilating once every 5 to 8 seconds. And if there is gastric inflation, get a second user to apply cricoid pressure, just like so. And what this does is it pushes the larynx posteriorly onto the esophagus, collapsing it. This prevents aspiration or further gastric inflation. Difficulty in using the BVM can be ascertained by using the acronym MOANS. This stands for mask seal, obesity or obstruction, age, neck mobility or no teeth, or stiff, or if the patient snores. Yeah. First vital sign I'll be taking is Martin's pulse rate. This will be taken at the radial pulse, which is lateral to the wrist, just below the thumb. The normal heart rate for an adult is 60 to 100 beats per minute, and when I'm checking Martin's pulse, I'll be checking for its regularity and its strength. An irregular pulse could indicate abnormal cardiac function, while a weak pulse could indicate heart disease. So hi Martin, could I just check your pulse please?
Sure thing.
Alright, and I'll be checking his pulse for 15 seconds. Alright, so during that 15 seconds, Martin's pulse was 20 beats. So I'm going to multiply that by 4 to get the beats per minute, which would be 80 beats per minute. This falls under the normal range of 60 to 100 beats per minute, and I also noticed that your pulse was strong and regular.
Okay.
Second vital sign I'll take is Martin's blood pressure. Before placing the cuff on Martin, I'm going to make sure that there's no restrictive or obstructive clothing in the way. So will I be able to place the blood pressure cuff on your bicep?
Sure, not a problem.
Alright, and when placing the cuff, just make sure that this marker, it's right on the brachial artery, which is medial to the elbow, and I can feel the pulse here. Right. So what we're looking for is the diastolic blood pressure, which is when I inflate the cuff, it's going to be the first beat I hear when I release it, and the diastolic blood pressure, which is the last beat I'm going to hear before it fades away. So I'm going to take my stethoscope and place it on the brachial artery, which I felt before, and I am going to inflate it until I cannot hear a pulse. Okay, so pressure is 124/80.
Okay.
And that your systolic blood pressure is in the general range of 100 to 135 millimeters per mercury, and your diastolic blood pressure is also in the normal range of 60 to 80 millimeters per mercury. So your blood pressure is normal. Assessment. I'll be observing the rise and fall of gases chest and abdomen for 10 seconds and multiplying it by 6 to get the respiratory rate. So guess, would I be able to do a respiratory assessment on you?
Yes.
Just breathe normally, right? Okay. So in the 10 seconds, you breathe 3 times. So I'll multiply that by 6, which gives me 18. This falls within the normal range of 12 to 20 breaths per minute. And also when I'm observing his chest, I'm also taking note of the volume and depth that he's breathing. You don't want him breathing too shallow or too deep. Okay. And now I'll do an auscultation just to check whether his lungs are clear and equal on both sides, and to check for any abnormal breathing sounds, which can be stridor, crackles, or wheezes. So guess, is it alright to do an auscultation on you?
Yeah.
This involves me placing the stethoscope just on your left and right clavicle, or just below the clavicle on the apex here.
Yeah.
Yeah, and just below your mid-maxillary line, so just left and right. So this here, and anterior and posterior, so this is 6 points. Is that alright with you?
Yeah.
Alright. And a deep breath. Deep breath. Deep breath. Deep breath. Good. So your lungs are clearly equal. So I've got a patient here with a suspected right tibial fracture, and before I do my assessment, I'm just going to gain consent. So Mr. A, is it alright if I remove the clothing covering both your lower legs? And I'll be doing, so I can do my assessment and apply a splint. You're going to feel so much better after the splint has been applied. Okay, so I'll just be exposing the injured leg and the uninjured leg as well, just so I can get a comparison of both. And I'll also be asking the patient how he got his fracture. The acronym I'll be using to assess his fracture will be PLASTIS. So I'll be asking him how much pain he's in. I'll be assessing for any loss of movement, so I'll be asking him to wiggle his toes and if he can move his leg. And when he's moving his leg, I'll be looking out for any unusual movement, any swelling, any deformity, any irregularities between the both legs, whether there's crepitus, so through movement or palpitation, and whether there's shortening of the limb. Before splinting, I'll be doing I'll be checking neurological and cardiovascular integrity, so I'll be feeling the temperature of both foot. I'll be testing for sensation by touching his foot and asking him whether he can feel it, whether he can feel me touching his toes, and I'll be checking capillary refill as well. And I'll also be asking him how much pain he's in using a pain scale, so that will help me determine the appropriate pain relief to administer. So sir, on a scale from 0 to 10, with 0 being no pain and 10 being the worst pain imaginable, at what number is your pain at? The patient has indicated that his pain is an 8 on the pain scale, so the pain relief that I'll be administering is Entonox, and this is because he is alert and able to obey commands, and Entonox is suitable for moderate to severe pain. So before giving any kind of medication, I will first be doing a drug check using the 5 R's. This consists of the right drug, the right dose, the right patient, the right time, and the right route. So after I have done my drug check, I'll be getting my partner to do their own independent drug check using the 5 R's as well. Contraindications of using Entonox include if the patient's unable to obey commands, if they've got a suspected pneumothorax, a suspected bowel obstruction, if they've got a known allergy, or if they've been diving in the past 24 hours. So I'll just inform the patient of what's happening. So Mr. A, I'll be administering a really powerful pain relief. It's called Antonox, also known as laughing gas. What it is, it's a self-administered drug that you inhale. So you inhale it through this tubing here, and after 5 to 6 breaths, you'll start feeling the effects, and it will definitely ease your pain. Some side effects of using Antonox include the feeling of euphoria, auditory disturbances, a metallic or dry mouth feeling after using it, but rest assured that is completely normal. So for splinting, I'll be using a box splint. So it's just made out of a cardboard box, and I've got a towel in here to provide some padding. I've got 2 triangle bandages underneath here, so that when we slide the splint under him, we can just tie it immediately and we do not need to move him any further. So I'm just going to tell the patient of what's happening. So Mr. A, I'm just going to be putting a splint. I'll be tying your leg to a splint, and it's going to make it feel so much better because it's going to provide some stability. Unfortunately, it's going to involve me moving your leg, but would it be possible for you to inhale some laughing gas before I do so, just to ease the pain, and just tell me when you feel the effects of it. Okay, so I'm just going to get a partner to help me. Okay, so could you just hold his leg while I slide the splint? Sure.
Alright, I'll do 1, 2, 3.
Yep, okay.
There we are. Very good.
Yep, okay. Just tie it one above.
Yep.
And I'll be tying the one below, okay? After splinting, reassess for cardiological and neurological integrity. So this is done by asking if you can feel me touching his toes, feeling the temperature of both legs, and the capillary refill. To assess whether a cervical collar will be applied, I will be using the Nexus rule. So a cervical collar is indicated if the patient has posterior midline cervical tenderness with or without palpitation, if the patient is intoxicated, if they have below normal levels of mental alertness, if they show signs of neurological deficit, or if they have other painful or distracting injuries. So if any of these are present, a cervical collar will be applied. So before I apply a C-collar onto the patient, I will first explain the procedure and gain his consent. So Mr. A, I will be applying a cervical collar onto your neck. This is just to immobilize your cervical spine. And is it alright if I get my partner to just hold your head in a neutral alignment while I measure and apply the collar? So he has given me his consent. So can I have my partner just put the patient's head in a neutral alignment like so, and I'll be measuring from the top of the clavicle to the bottom of the mandible like so. So I will be measuring it on the cervical collar here. So I've just got to adjust it, and you do it just by clicking these 2 locks up and pulling it to the desired length like so. So before applying the collar, I'm just gonna pre-bend it just to ensure the application is easier. And when applying it, ensure that his ears are not caught or folded with the cervical collar. When cervical collar is properly applied, it will maintain the patient's, the neutral alignment of the patient's head. As blood may be involved, ensure that correct PPE is worn, such as your gloves and your safety glasses. So first you expose the wound and clean with normal saline as necessary. Cover the wound with the smallest possible dressing to ensure that maximum pressure is applied on the wound. So in this case, I'm going to be folding this dressing like so and applying it directly onto the wound. Next, when you bandage, twist and tighten when you're traveling over the wound, like so. So twisting and tightening when you reach the wound. And once you're done with that, just tuck it in like so. And if bleeding continues, apply a second dressing on top of the first dressing. You can also elevate the limb like so, or you can apply indirect pressure using a crepe bandage this under the arm, and this can help arrest the bleeding. Yep. When applying a tourniquet, apply it to the upper proximal bone of the extremity at least 10 centimeters proximal to the wound. So in this case, like so. Okay. Tighten the windlass until the distal pulse, or in this case, the radial pulse, cannot be felt, and record the time and date of when the tourniquet is applied. If bleeding continues, you can apply second tourniquet immediately proximal to the first tourniquet. When a tourniquet has been applied, never remove it, and if the patient is conscious, analgesia will be required before applying. How to use a Life Pack 15. So what you do is you just turn it on.
Push Analyze.
And you just press Energy Select to get it into the manual mode. Is it not coming? Okay. And then you just highlight manual mode using the dial to maneuver. You just turn this down to 50 joules. So now that you're in manual mode, you want to do a user test first. So you highlight user test, and while that's printing, you just check all your compartments. In this compartment, we have our SpO2 and CO2 devices. We also have our ECG leads, which is connected to the patient over there. In this compartment, we have our defect pads. We also have our GTN, aspirin, and ECG dots, and we also have a shaver if we need to use it. So now we're just going to look at the user test. So it's passed the user test, so that's good. And now we're just going to do a test charge. So what you do is you press charge, and it will load up to 50 joules, which was what we set it to before. And you just press the shock button. So yep, that shows that it can deliver a charge. And now we want to see if it can disarm a charge. So you just press charge again, and before it reaches the full, and you just press that, and it's disarmed the charge. So now you want to see if your monitor can change the size of the leads. So you just click size here, and you can choose between a bigger size or a smaller size, but we'll just leave it as 1. You can choose a different lead as well, and you do that by pressing the lead button, and you've got all your different type of leads over there. So we'll just leave it as lead 2, and now you want to see if your monitor can see the different, change the QRS size. So you highlight heart rate using the dial, click that, you click it again, and now you can just change your QRS volume there. So just leave it as where it was, and you just press the home screen to go back. And now your monitor will come with a blood pressure cuff, and you just attach that to your patient's arm, and you press NIBP, this button here, and it will read your blood pressure for you. We also want to check if there's enough paper in the life pack, so you just pull this little lever down, and yep, there's enough paper, so that's good. And if need be, there's extra paper at the back. So for our final check, we just want to put it back in AED mode, and you do that by pressing the Analyze button.
Analyzing now. Stand clear.
So to check the battery of the monitor, I'm just going to flip it around here, and the batteries are underneath here. So these two things are the batteries. So to check the levels of each battery, just press this gray button here. And this has 3 bars, this has 1 bar, so this needs changing. And to remove it, you just click this thing and it should go like so. Approaching the patient, I'm just going to ensure that the crew have the correct PPE, so that's safety glasses and gloves. And I'm just going to assess for any dangers that I can see, smell, or hear. So there are no dangers, and I'm just going to approach the patient. Hello sir, can you hear me? If you can you open your eyes for me? Hello sir. There's no response to pain or verbal communication. I'm just going to check his airways for any obstruction. There are none, and I'll just check his breathing for 10 seconds. He's not breathing. Lee, can you start CPR? AUT 12 comms. We have an R49 requesting R50. Okay. I'll just be putting an AED on him.
Analyzing heart rhythm.
Okay.
Do not touch the patient.
Analyzing now. Lee. No one touch the patient. Okay.
Shock advised.
Shock advised.
Charging.
Everyone's staying clear.
Stay clear of patient.
So just everyone's staying clear.
Deliver shock now.
Alright, stay
Press
clear.
the orange butt shock. Deliver.
Alright, Lee, can you start CPR,
Four.
please? Alright.
Start CPR.
I'll just be putting an OP in him just to maintain his airway, and I'll just prepare my bag valve mask, which I'll be ventilating him twice after 30 compressions. So Lee, can you tell me when you're done 30 compressions? I'll just check this oxygen in here, so you can hear that, it's really good. And I'll just check whether my suction unit's working. Like, it's working. Okay, so 1 chest rise, 2 chest rise. Lee, can you continue CPR, please? Alright, so now I'll just be asking anyone if they know what happened to the patient. Do they see what happened, or do they know of him? Family and friends of the patient can usually give some good history of the patient. And when doing CPR, it's at a rate of 100 compressions per minute, and the depth of CPR will be 1/3 of the chest size. So just tell me when you've reached up to 30. Okay, can you continue CPR, please? You're doing really well. And when doing CPR, just ensure that there is full recoil, just like what Lee is doing here. That's really good. And after 2 minutes, we'll be changing position just to ensure that CPR remains effective. One chest rise, 2 chest rise. Can you continue CPR, please? And when using the bag valve mask, I'll be adopting a C-clamp just over the patient's face, just to ensure that the seal is tight and that air is not leaking out when I'm ventilating. 1 chest rise, 2 chest rise. And when ventilating, just always ensure that there's chest rise.
Stop CPR.
Yeah. Okay, I'll stop with you, Lee.
Analyzing heart rhythm.
Okay, analyzing everyone's
Stay clear of
Stay
patient.
clear. Stay clear.
Analyzing heart rhythm. No shock advised.
Alright,
Pause.
let's start CPR.
If needed, start CPR.